be talking a little about more advanced heart failure therapy here, and kind of the selection criteria, how we go through evaluation these patients, and also we talk about the advanced heart failure options that we have as of now. As you know, the heart failure is a major issues with the about 6 million people in the US and 30 million people worldwide has heart failure, and it's projected in 2030 about 9 million people in the US are going to have a heart failure. And there's no more increasing number of the people progressing to the stage D heart failure as their therapies and medication are getting better and people survive longer. The heart transplant and the LVAD are only approved non-pharmacological therapies for these patients. So this is kind of the classification that we look for the heart failure patients. There are different classifications. There's ACC, NYHA, and Intermax classification. So the ACC are stages. There's stage 1, stage A, B, C, and D. So stage A are the patient with a high risk but no structural heart disease and no symptoms. Stage B are the patients with a structural heart disease but no symptoms. Stage C are our bulk of our heart failure patients that we see, that they have a structural heart disease and they have symptoms. And stage D are more refractory symptomatic heart failure. Yeah, so we talked about the stages, and the NYHA class are basically based on the symptoms. The NYHA class 1 are no limitation with normal physical activity. NYHA class 2 is a mild symptom. NYHA class 3 the moderate symptoms with during the daily activity, and 4 are the severe limitation or symptoms addressed. And for more advanced heart failure patient, the Intermax profile, we look at it. So the profile 7 are basically patient with the NYHA class 3. Profile 6 are exertional limitation. 5, they have exertional intolerance. 4 they have a symptom at rest. 3 are on inotrope, dependent on inotrope, but stable. And 4 have a progressive decline. And profile 1 are a critical cardiogenic shock patients. So when we should think about advanced heart failure therapy in these patients, this is the kind of projection of the heart failure. So after diagnosis of the heart failure, they do maybe stable for a while, and over time, this is kind of the quality of life decrease and mortality is increased over time. And there are some higher and lower of how they do. They do worse. Maybe they get some therapies, they get hospitalized, they do better, they stabilize for a while. And overall, this projection can be toward the worsening of the symptoms and quality and quantity of the life. And as this happening, the number of the medication that we can offer decreases, and then we start thinking about more advanced heart failure therapy. So in the ideal situation that we can predict when is the best time for these therapies, including the LVAD and transplant, if they're too well that they're not going to benefit, or they're too sick that they will not benefit, and if you can predict the right way. But unfortunately, what happens in the real life, that's what happens. Some patients, after diagnosis, they decline very quickly between these two dashed lines at the time that they would benefit optimally from this therapies, the LVAD or transplant. Some patients, they slide very quickly, and they might have a very short time for us to evaluate and make a decision. Some people kind of decline a little bit slower, and we have a little bit more time. And some people, they might do well for a while, and we're thinking they're too well, and they don't need this therapy, but they might decline very quickly, and we might have a very short time to evaluate, and we can take action for this patient. So how we can pick up this patient, and we see when's a good time for a referral or evaluation for advanced heart failure therapy. The ejection fraction is the measurement that we use a lot. We talked a lot. We know the low ejection fraction is bad. Less than 30-35% is increased with the associated increased mortality. However, when you go below 30-35, it's not a very good predictive of mortality of this patient do. Between 25 to 20 to 15, they have a very low the high mortality, but it's not a very good way to identify which patient we should trigger the evaluation or moving to the next step. There are multiple scores that we can help us to evaluate this patient and risk stratify them. One of them that I like is a Seattle heart failure model. This is put in consideration a lot of patients' characteristics, including age, gender, NYHA class, their EF, their blood pressure, the medication that they're on, their lab work, and also the devices that they have. And then it gives you a graph, basically tells you what the mortality is next 5 years. And what is good thing about this that you can show this to the patient and they tell them which each therapy, either adding ACE inhibitor or R, beta blocker or ICD, how that they change their mortality over time. That's the way actually to kind of talk about this patient, see what's the benefit of these therapies are. So it's a good tool to use. The hospitalization by itself, it's a predictive of a poor outcome. The higher the number of the hospitalization, the worse this patient they do. If they have 1 versus 4, is a big difference of how they do over time. So that's another way to look at it to see if the patient gets hospitalized multiple times in the last few months. That's another indication that we should think about next step without this patient. The cardiopulmonary stress test, which it's a talk on its own, and Dr. Hussain gives that talk. This is what we use a lot to risk stratify this patient. And then we have some parameters like VEV-CO2, the maximum peak oxygen consumption. It's a way for us to risk stratify this patient. And we have some cutoff that help us to identify patient with advanced heart failure therapy. For example, peak VO2 less than 14 for the patient on beta blocker and less than 12 for the patient that they're not on beta blocker. So whence we should consider evaluation for advanced therapy? If they have multiple hospitalization, if they have progressive declining in renal function, weight loss without a cause, which is also cardiac cachexia, intolerance to neurohormonal therapy, intolerance to beta blocker, if the blood pressure is low and we start removing the neurohormonal therapies because of the low blood pressure, persistent dyspnea and very symptomatic, inability to do daily activity, and the recent escalation of therapy like diuretics and progressing declining the sodium and frequent arrhythmias and ICD shock. Those are some of the red flags that we should think about for us to consider to move into the next step. So that's what happens when the patient with a chronic failure, if they have a chronic failure, we have to look at the reversible causes first. If they're ischemic, if they have benefit from revascularization, if there's anything that we can do to improve them. This is a hypothyroidism, hyperthyroidism, they have a toxin that we can reverse. After that, we look if they're optimized. If there's a medication that we can add, like Entresto, switching into Entresto from ACE inhibitor. If they have a severe mitral regurgitation, we can do the mitral clip for a cohort of the patient. If they would benefit from the CRTD. So we try to optimize them. After optimization, if they still have a symptom of they have a cardiogenic shock or they're one of those red flags and they don't improve, then we see if they're a candidate for advanced therapies. If they are, then we should think about LVAD or transplant this patient. If they're not, we should go to the route of the palliative therapy and hospice of this patient. So we will talk about some of those 2 therapies that we use for this patient. But one of them is a heart transplantation. So how we think about the transplant and listing this patient. These are some of the guides that we use for listing the patient. As we talked about, we use the cardiopulmonary stress test, and if they reach the anaerobic threshold of the RER more than 1.05, then we have some cutoff for the peak oxygen consumption to kind of guide us that these patients are doing well and they're not doing well, and we need to think about advanced heart failure therapy. However, a very important point that we never use just one number to list this patient. We should look at all other stuff. Again, their symptoms, their right heart cath, have to put everything before listing this patient. This is just a guide for us to think about and risk stratify this patient. We have some cutoff for a peak oxygen consumption. And there are some other parameters that we look. For example, if the patient is young, we mostly look at the predicted peak oxygen consumption less than 50%. If they don't reach anaerobic threshold, we use the ventilatory efficiency slope VEV CO2 more than 35 as a guide. And in some circumstances, if there's we can use the scores that we talk about to guide us to stratify this patient. All these patients that when we start thinking about the advanced heart failure therapy, they should have a right heart catheterization. That not only give us the filling pressure, the cardiac output, it also help us to have a plan going forward what we're going to do for this patient. For example, if they have a pulmonary hypertension, if this is reversible or not, that's going to make a difference if they're a candidate for heart transplant or not. If they have a BIV failure or just a LV failure, so we have a plan. If they need a mechanical circulatory support, what options do we need to have on this patient? So right heart cath is very important for this patient. There are some absolute contraindication for the patient that for the listing. If they have a systemic illness and life expectancy less than 2 years, they're not a good candidate for a transplant. They have the active or recent malignancy, and they have an AIDS with frequent opportunistic infection. If they have other organs, for example, kidney or renal involved, so heart only, it's not an option, but then we were talking about either they're not a candidate or we think about a dual organ transplant for this patient. Severe lung disease, again, if they're not a candidate for heart, do they need a lung transplant? We have to kind of evaluate them that way. Active substance abuse, poor compliance with medication, and fixed pulmonary hypertension. There are some relative contraindication, for example, tobacco use, active alcohol abuse, if they're diabetes with the end organ damage, peripheral vascular disease, which will limit their activity and rehabilitation after that, if they're a psychosocial issue, non-compliance, or obesity, which is they're cut off based on a different centers, like more than 30 or 35, depends who you talk to. So after we pick this patient, so now we go into evaluation and we think this patient are good candidate for a transplant. The next step is listing this patient. So depends on how this patient do and then when they are on their heart failure process, they can be listed one of these status, 1 to 6. So the sicker they are, they're higher status and they have a higher priority to get transplanted. Status 1 are the patient with the biventricular failure and they're on the ECMO or on non-dischargeable by V support. Status 2s are patients that you guys see mostly in the ICUs with having either balloon pump or Impella and they're waiting for a transplant, or they not have a non-dischargeable LVAD. There are mostly status 2s, or they have arrhythmias with the VT, MVF, unmechanical circulatory support. Status 3 are the patient who have they have a SWAN GANS, like a monitoring in the ICU, and they're on inotrope, and also if they have LVAD with complication. Status 4 are all our LVADs usually go to a status 4, and they have if they have a specific diagnosis like a congenital heart disease, ischemic heart disease with the intractable angina, hypertrophic cardiomyopathy, restrictive cardiomyopathy, amyloidosis. Status 5s are our dual organ patients, like heart and kidney, heart and liver. And status 6 are all other patients that they don't meet criteria from status 1 to 5. There's another status that hasn't been mentioned here, is the status 7. The status 7 is our patient that there's something happening there we think we should inactivate them temporarily. For example, somebody comes with an infection and you want to put them status 7 so we don't accept the organ for them till that issue resolves and then they go back to their status they were before. So here's the volume of the transplant. So the yellow bars are Europe, the green bars are the United States, and then red bars are the other countries. So as you see, over last years, there have been increasing number of the transplants. So in the United States, we transplant somewhere between like 2,500 to 2,000 patients a year. And that has been increasing because of the donor availability with the opioid epidemic in the United States. And also there's an increasing number of the transplant in other countries as well, which has increased the number of the transplantation. So donor heart selection, like how we selected these donors. So the donor age is very important. There's some cutoff that we have some guide for. If it's less than 45, they usually we consider for all the donors. 45 to 55, they have to consider other parameters. For example, there's low ischemic time. And we also have to consider some recipient factors. For example, if they have a pulmonary hypertension, maybe it's not a good, for them. If they have a redo surgery, we have to consider all these parameters. If there's 55, is rarely we consider for the patient that we think they're really going to benefit from this transplantation. We can consider for those patients. These are who are the get transplanted. The recipient age is average is about 55. The donor age is about 35, and it's different in different countries. In the United States, donors tend to be younger, an average of 28 years old. And Europe, the donors are older, with the average years of 44-year-old. The other consideration, when we should not accept the heart, if the heart has intractable ventricular tachycardia, if they need a very high inotropic support, which is equivalent to the exceeding of dopamine of 20 microgram per kilogram per minute, if they have a distinct wall motion abnormality on echo, EF less than 40%, if they have a significant coronary artery disease, if they have if they have a LVH with the wall thickness more than 14. The size is the next thing that we think about when we get the call on these patients. So the general guideline is for us that if we go by the weight, the recipient, the donor weight should not be more than 30% lower than recipient weight. And then if it's a female to male, that's 20%. However, if you look at the graph on the left side, these are the donors' the discrepancy, that more less than 30% up to more than 30%. How they do after transplant, they're not very different actually. So that's why we kind of recently been using the heart mass as the better indication of the size match rather than the weight. So there's an app and there's a formula that you can calculate actually the heart mass of the donor and the heart mass of the recipient. And if it's more than 20% difference, these graphs start separating from each other. So we try to get the donors who match heart mass not more than 20% lower. The next thing is we consider is a sex match. So how we do as a female to male, male to male, so the general is, male to male, female to female obviously is accepted. Male to female, it's acceptable. When it comes to female to male, we have to be really careful because usually the female heart mass is lower than the male. And if you see there's a separation here from the red line with the female to male, they do slightly worse. But if you look why they do worse is because the female to male, they tend to be sized lower. So female donor to male recipient is like that navy color. So they usually pick the lower, look at it with the heart mass, they actually has been lower on the heart mass. That's why they do worse. So the bottom line is if you have to use the heart mass and you find the right size, it should be okay to use the female to male, but it has to be a little bit with the cautious and going a little bit maybe bigger heart for that. The ischemic time is another consideration. We see how far the donors from recipient. Again, that's kind of important with the newer allocation because that gives us a little bit further reach to see where we can get these donor hearts. So the ischemic time less than 4 is usually the ideal situation. When it gets more than 4, you see these graphs are getting separated, and more than 6, they really do worse on the follow-up. So we try to keep the ischemic time less than 4 for these patients. So kind of looking a little bit of indication of the heart transplant, who gets transplanted. So overall, most of the people that they get transplanted, they have either non-ischemic or ischemic heart disease. In the United States, there are more ischemic that they get transplanted. And also there are other like a congenital and valvular disease of some patients that get transplanted that way. And as far as the mechanical circulatory support and LVAD, over last year here, if we have it from 2005 to 2016, more and more patients are getting transplanted as a bridge to transplant. If you look at this trajectory, I don't have the data here, but somewhere between after 2018, when we changed the allocation system, the bridge strategy has changed in some of the centers, and then we see more patients getting transplanted from the temporary mechanical circulatory support like a balloon pump and Impella, and less patient getting transplanted from the LVAD. As one of the reasons is because the priority has changed, and the status 2s, which are temporary support, they get transplanted sooner, and LVAD are kind of dropped to the status 3 and 4, depends on the complication. So how do these people do after transplant? These are the first graph on the top is the survival based on different eras. We are getting better over time. We're somewhere between about like a 13 years median survival. Depends on etiology. They do different. So ischemic, non-ischemic, they usually do better. In the first year, the middle graph is the first year. The patient with a retransplant and congenital, they do worse. However, if you follow on the long term, the congenital patient, actually the yellow line, they do better over time because they're younger if they pass the first year. So some other consideration there. This is kind of a few tips about post-operative care for the heart transplant. When this patient comes to the ICU after heart transplant and you're on call, what some of the things to consider how to manage this patient. So we have some guideline about the monitoring these patients. So they all have to be on the tele. They have to have an invasive A-line. They have to have a Swan-Ganz catheter or a way to measure the RA, the left atrial or wedge pressure, and the intermittent cardiac output. Be able to monitor their ABG, the arterial oxygenation. The intraoperative TEE is recommended for this patient, and they also have a way to measure their continuous urine output. So some of the issues that they come with this patient and how to consider management, the pericardial effusion. So some of these patients, you see a lot of pericardial effusion after transplant. One of the reasons is because their native heart or their heart was usually they have a cardiomyopathy and they have more space, and now you're putting a normal sized heart. So you see this pericardial effusion of these patients, not uncommon. So pericardial effusion should be monitored closely by echo. And if there's any hemodynamic compromise, especially after the transplant and their ICU, you should think about tamponade of this patient, and it should be a very quick response for the surgical exploration and removing the clot and blood around the heart. And if there's but sometimes if in the long term, especially after the discharge or while you follow up, if you see the cardiac pericardial effusion, but there's no hemodynamic compromise, it's reasonable to monitor them by echo. And what drugs we use for these patients? So most of the patients, they come out the operating room with on the multiple inotrope and the pressor. For example, epi, dobutamine, some of them they need a vaso during the operation. So we try to start weaning off this patient as we're closely monitoring with the hemodynamics. Some of the suggestion of medication that we use is a dobutamine and dopamine, Miranon, epi, and vaso are kind of the drug of choice, depends on the hemodynamic and blood pressure of this patient. So these has to be kind of very closely monitored, and we have to have a reason why we're doing that. This is because of the low cardiac output, because of it's a vasoplegic patient. So we have to kind of have understanding of this inotrope and pressor, how they work, which receptor they work, what they interact with. So that's going to have, so we pick the right drug for this patient. So the right ventricular failure and pulmonary hypertension is not uncommon, one of the issues with the post-transplant. So we have to, first we have to see if somebody is unstable and we see that the CVP is going up right after a transplant, the first thing I would think is a tamponade of this patient. We really have to rule that out. If not, then we have to look to see if they're volume optimized, if they lost a lot of blood, or a lot of blood is coming from the chest tube, if they need a fluid resuscitation. So that's why we have a swan and echo. We have to monitor him that way. If they have a lot of volume on him, start diuresing them. If they're not responding, low threshold for putting them on dialysis in a short period of time to remove the pressure from the RV. If we rule out other causes. If there's a PE, for example, it's something we should think about. And then we pick a drug to support the RV. Dobutamine, Miranon, epi, nor epi, depends on what's going on hemodynamically. Also, don't forget about the nitric oxide inhale. We use it a lot for the patient for afterload reduction for this patient for the RV support. So these are some of the considerations that you have to think about for a post-transplant patient. Mechanical circulatory support after transplant, again, we have to decide very quick on this patient. If they cannot come off the cardiopulmonary bypass, maybe they would come out the OR with some type of mechanical circulatory support. If they come without it and the cardiac index is dropping, the mixed venous is continuously dropping regardless optimization of their volume status and drugs, I think mechanical circulatory support. Don't wait for a long time. And if there's no evidence of the graft dysfunction and there's still, we should think about the hyperacute and antibody-mediated rejection of this patient. And if they're not doing better, we should start thinking about retransplanting this patient and putting him on the list. Arrhythmias, so they have, this transplanted heart, they have some of the arrhythmias associated with that. So as you know, these hearts are denervated, so they supposedly go a little bit higher heart rate. I mean, in the beginning, we wanted to keep them on a higher heart rate, at least about 90 beats per minute. So all these patients are coming out with temporary pacer. They have an A and V pacer. So most of the time, ideally, we want to pace them in the A and then give the PR interval a little bit longer to see if they can conduct. But if they're not conducting, you should have a backup V pacing. It's better for them to get initially V pace rather than very slow ventricular response initially. And if there's a persistent tachyarrhythmias, and if they're, for example, if they're bradycardic for a long period, and then there's an inappropriate chronotropic response, some of the patient would need a permanent pacemaker before discharge for this patient. And the class 3 antiarrhythmics, amiodarone, for mostly you can use them for some of the patient, but for a VT and AFib, has to be kind of with cautious of this patient, but it's reasonable to use for this patient. Some of the causes of the death for the transplant patient, how this patient do over time, and what are the complications for this patient. Early on is a graft failure and infection, multi-organ failure, and then later some of them, like a graft failure, still is an issue. Infection can stay still high. But over years, like after 5-10 years, there are other issues start coming up, like a malignancy, cardiac allograft vasculopathy, renal failure, contribute to the cause of mortality too. And then the first one is just kind of follow-ups for each cause. And the second one is a cumulative incidence cause of death for this patient. For example, the graft failure sees over time still as the highest compared to everyone. But we have to kind of consider all of those causes as well. So this is a little bit a background about the heart transplant. But as you know, kind of we mentioned the volume. There's just we transplant about 25 to 3,000 patients a year, but the number of the patient with advanced heart failure, stage D heart failure, is getting higher and higher, and that's where the LVAD came in play. So LVAD, left ventricular assist device, utilization after was approved for destination therapy and was approved for this patient. There was an exponential number of the center and number of the patient who went under LVAD implantation. So basically, LVAD is a pump that sits in either in pericardium or in the pocket, and the inflow cannula is in the LV. The outflow cannula is in the ascending aorta, and then just takes the blood from the LV and goes to the pump and eject it in the ascending aorta. It can give you up to 8 to 10 liters of the flow based on the speed and preload and afterload. How we use the LVAD for indication. The two main indications are bridge to transplant or destination therapy. Bridge to transplant are a patient who are listed for a heart transplant, candidate for a heart transplant. They are NYHA class 4, and they have a hemodynamics that they're low cardiac index, high wedge. They can get implanted for a LVAD while waiting for a transplant. Destination therapies are for patients that they're not a candidate for a transplant for some reason, but they might benefit from the LVAD, and there are some criteria that they have to meet. Low EF less than 25%, they have to have a low peak oxygen consumption, and they have to be on the optimal medical therapy or requiring some type of mechanical circulatory support. And initially, the LVAD was approved for a bridge to transplant, but after approval as a destination therapy in 2010, the green line on the lower corner, you see there's a exponential increase, and more patients get implanted as destination therapy rather than bridge to transplant in the recent years. And how they do over time, this is like all the LVADs. The 1 year's survival about 83%, and 5 years survival about 50%. Survival is usually lower in the destination therapy patient, the green line, and usually this is mostly because these are the patients that they're not a candidate for transplant, so they have a higher comorbidities. They're older, they have diabetes, they have a renal failure, so they have a higher comorbidities, and they usually do worse than patients with a bridge to transplant. So the patient selection obviously is very important in this patient. We want to include the patient who will benefit from the therapy, and we want to exclude the patient who would not add any meaningful survival for this patient. So this is just kind of the graph here, the table. I'm not going to go over the detail, but there are some indication based on patient characteristics, the right heart findings, the non-cardiac etiologies in the lab that kind of tells you who would do worse in the early and who would do worse later in the LVAD. And also in the Intermax, the sicker this patient, they go to the LVAD. For example, profile Intermax 1 and 2, they do worse, at least initially. In the long term, they might kind of catch up and do the same as other patient, but initially they do worse going to the LVAD surgery. So the next, I'll kind of talk about some of the pumps that we have available. This is more historical, but this is the pulsatile HeartMate XVE. And the advantage, there's a pump that put the LVAD on the map, and from the REMATCH trial, which I'll show you a slide, the next one. The advantage is the internalization of the pump. It has a reduced external size. Disadvantage of this patient, the durability was very low, and they required a lot of surgery and replacement of this pump. But that's kind of the pump that REMATCH trial was done on. This is a comparison of the patient with the medical therapy versus LVAD, and there was a 48% reduction in the risk of mortality. That's how the LVAD was improved as destination therapy. The next pump, which probably you guys seen a lot, is a HeartMate 2. It's a continuous axial flow pump. It's has a greater durability, is a smaller device, but it does require having a pump, having a pocket to place that pump. And the way it was approved, this pump, they looked at the patient with the advanced heart failure therapy, and they looked at the outcome in 180 days. There was 75% who met the outcome, which was a heart transplant, heart recovery, or alive on the LVAD. And also they looked at the patients who were listed for a status 1A and 1B. Similar things, about 79% met the primary outcome in 18 months. They either get transplanted or had a heart recovery, or they were still alive on the LVAD. That's how the HeartMate 2 was approved as a bridge to transplant. And later on, this was compared to the pulsatile flow, and there was a superior pump. It was 1 year survival, was 68% the continuous flow versus 55% of the pulsatile flow, and 58 and 2 year survival, 58 versus 24%. And also look at the stroke was similar. However, reoperation was lower, and death in 2 years was lower. So definitely was a superior pump to the pulsatile XVE. That's how it was approved as a destination therapy. And after that, really that XVA pulsatile flow LVAD was discontinued and was not implanted after that. The next pump is HVAD or hardware. This is it is still continuous flow pump, but it's a centrifugal pump and is entirely contained within pericardial space. It is a smaller pump. And the way it was approved for bridge to transplant was an advanced trial, non-inferiority trial, HeartMate 2 versus HVAD, and they do that as the primary outcome is survival on the original implant device, or they got transplant. They were same, so it was non-inferior, was approved as for bridge to transplant. And in the Endurance trial, looked at the destination therapy patient, and they met the non-inferiority outcome, so was approved as a destination therapy. The newest pump is a HeartMate 3. It is kind of, you see the design is very similar to HVAD, however, it has some features that makes it a very attractive pump, which I'm going to go over them in the next slide. So it is a centrifugal pump, is a continuous flow, but has a wider blood flow passage, so reduce the shear stress, and has a intrinsic pulse. What does it mean? Is that the speed goes up and down, and that's the theory behind this, kind of wash out the pump and then prevent the stasis and thrombosis of these pumps. So if you look at the full cohort, they compared in the Momentum 3 trial, they compared the HeartMate 2 with the HeartMate 3, about 500 patients in each group. They looked at the primary endpoint, survival at 2 years with the free of disabling stroke or reoperation replacement. Definitely superior pump, 74% versus 60%. Looked at the other secondary outcomes like a pump replacement, definitely superior pump, 96% without pump replacement for the HeartMate 3 versus 84% for HeartMate 2. For any cause of stroke, it was a superior pump, did better. The stroke rate was much lower in this HeartMate 3. And GI bleed, similar thing, was a statistically significantly lower for the gastroenterology bleed. And kind of, we look at all the hemocompatibility related adverse event, look at any stroke, hemorrhagic, ischemic, disabling stroke, any bleeding, pump thrombosis, all of them are better with the HeartMate 3 versus HeartMate 2. That's kind of, we're shifting towards, more using HeartMate 3 recently after Momentum 3 trial. Kind of summary of all the pumps that we have available. It will be available to you guys to look at it. Basically, how much they weigh, how much the cardiac output they would give you, what's the range of the speed that we usually see on these pumps. So the contraindication for an LVAD implant for a long term, if the patient is severely hemodynamically unstable, they're not going to do well. That's not it. We don't usually use the LVAD as an emergent implant. We need to stabilize this patient for the temporary pumps first before going into durable pump. If they have a irreversible major end organ failure, like a renal failure or liver failure, major coagulopathy, significant right side failure can be a contraindication because you support the left, but the right can be is not supported and can give you a lot of trouble. If they have an uncertain neurological status, if the patient is intubated, we cannot wake them up, that's not the time for implanting the LVAD. If they have a need for mechanical ventilation, that's not the time to do it. Or if they have active sepsis or vasodilatation symptom, we don't want to implant the LVAD at this point. Some of the complication, the LVAD has a lot of complications, as you guys seen probably the patient that get implanted in the hospital after that. Multi-organ failure, they have a lot of patients with the renal failure. One of the reasons is because going to the LVAD, this patient have a lot of comorbidities. Infection, driveline infection, or the VAD infection is an issue. Neurological, the stroke is a devastating cause of morbidity and mortality of these patients. Either there's a short to shield, there's a device malfunction, VAD thrombosis, and all those things. That can be some of the complications with the LVAD. So at the end, the kind of the message, the LVAD and transplants are available. We have to think about these patients earlier on. We don't want to wait for them to get too sick, kind of lose the opportunity. So think about this patient, think about advanced therapy. Again, that doesn't mean they're going to get the LVAD and transplant the next day, but at least it's good to know this patient, get their workup done to see what else we need to work them, they need to work the patient or us who work on for them to get them qualified for the LVAD or transplant down the road. The multidisciplinary approach is very important. We work very closely with the surgeons, the renal team, kidney team, and it's important to get everybody involved earlier in the game to see what are the outcomes is, and then if they're qualified or not, and then what options do we have. So we should have a plan. If the patient, they come, they're okay right now, EF of 10%, they're kind of borderline. It's a good time for us to have some type of plan the next time they come with a cardiogenic shock. So we have to have, it's good to have a plan what we're doing with these patients. Are they candidate or not? How aggressive we need to get with these patients or not. So that's all I have. I'm happy to answer any question.
Dr. Yousefzai, there was a question on the chat box that came in. You want to pull it up?
That's a question about the available RV mechanical circuit support or ECMO. When should we consider atrial septostomy in the acute RV failure? It's an option. To be honest with you, it's not something commonly used. If somebody in a really bad RV failure, and depends on what's going on, at that time. This is if you think this is a post-transplant patient, it comes with has some RV failure, and depends what's going on. If it's a tamponade, the acute heart failure, and we can optimize, usually go that route. If they need it's a temporary mechanical circulatory support or ECMO, that's probably if a temporary thing is usually we stabilize them at that time. And it's there for us to consider. It's not commonly done. I don't know if any of my other colleagues have any comment on the atrial septostomy. Is Arvin is there or? Yeah, I'm on my own. Not a lot of experience with that, and we don't use it very common. It's available there as one of the basically it works as a pop-off. If somebody has a very high RV and then you cannot really diurese them, the CVP is still very high, and that RV is just kind of struggling. It's a pop-off valve that kind of gets the pressure from the RA to LV while we figure out. But most of the time, at these areas we're usually going by some type of mechanical circuit support or inotropic support rather than septostomy.
Dr. Yousefzai, I had a couple of questions.
Yeah.
So when we're looking at when we're evaluating patients for a transplant, I know we said that people that have active malignancy, it's kind of like an absolute contraindication. But if it's a cancer that has like low mortality long term, like for example, like thyroid cancer or like prostate cancer, are those patients considered or no?
Yeah, no, definitely. I think we just doing like individual. Some of the patients that, as you said, there are some of them that are very low, mortality rate, and then very low progression of this disease. That we work with the hematology close with this patient. We get them, we ask them about their mortality rate and all those things. So if there's somebody that the mortality they're gonna live for like their mortality is like 10 years, they would definitely consider them. So these are more for active aggressive cancer that they have. Definitely the contraindication. And if it's completely cured, was just a local excise done, they are a candidate for it. And anything in between, we really have to rely on the oncologist to tell us what's their survival.
Okay. And then the other question I had was, so also when we're evaluating patients, we always say that patients look frail. Like, oh, this patient looks robust, this patient looks frail. Is there anything objective that we look at to determine that, or it's just kind of like eyeball test?
No, that's a really good question. So there's a frailty test. So there's a score that we do it. our coordinator, most of them, they do it. They how fast they can stand up, the grip and everything, and give you a score. And there's a really good correlation how these people do with the frailty. So there are frailty scores that actually you can put them objectively for the frailty score.
All right, and then I had one last question. So when we're having for LVAD, so I know we see a lot of patients that get pump thrombosis and they get bleeding. Do we ever screen patients for hypercoagulable state or anything like that, or is that not something that we do?
Yeah, I mean, there's if there's a reason for them, if there's an unexplained, for example, DVT or PEs, or they have a, so we do screen them for them. We get them all the hypercoagulable panel for this patient. If there's no reason, somebody never had any thrombosis in the past, no DVT, no PE, no delivery issues for the women. Not typically done very detailed, but if there's any reason, we definitely screen them for them, because we have people with the antiphospholipid antibody, which was positive, and we have to have a plan for them, and then we kind of have a imperative, start them heparin sooner, and then have the INR goal higher for these patients.
Hi, Dr. Yousefzai, this is HJ. I had a question about CPET test.
What test?
Sorry. The CPET test and the
Yes.
cutoffs that you have. Could you explain again why the lower cutoff for beta blockers? And then is there any controversy in using CPET test or something like that? I didn't follow, but there was some discussion on Twitter about how this is like an older method and sometimes not used in some centers.
Yeah. So this is all the CPET, the cutoff was based on this study, very old study from Donna Mancini, which was done. And the cutoff was kind of created from that. At that time was less than 14 for the patient not on the beta blocker. Later on, the reason that the patient on the beta blocker, they have a lower cutoff because they do better. They do better. Patient that can tolerate beta blocker, so they do better. So we have a little bit more time. So that's why the cutoff is a little bit worse for this patient. Okay, it is a older method. We use it a lot because again we don't go by one cutoff. We never say let's list this patient because the peak VO2 is less than 14. That never happened. But if somebody has some symptoms, right, we're still on the fence, like how this patient is doing. His EF is low, but he's still out. He's not needing inotrope. Then the CPET is really helpful for this patient because really can risk stratify this patient. And there's really good correlation how these people do over time, depends on the peak VO2 and also VEV-CO2. So it's a really good indication to how risk stratify this patient and how close we need to monitor this patient. So we use them for that, but we never use it for a absolute indication for listing or not listing of this patient.
Dr. Yousefzai, I had one question as well. In the immediate post-op period, you were talking about effusions. Is there a reason surgeons don't prophylactically put in like a window in the donor graft just to prevent that?
Yeah, I mean, most of these people, they don't need window. So there's no strong reason to do it because they put chest tube, and then the bleeding is supposed to stop. When the bleeding stops, really this patient, they do well. They don't need a window. Window usually use it, sometimes if the recurrent pericardial effusion or like a constricted type of picture they have. But most of the people, they don't need window. Rarely you need a window at this patient. That's why it's not done prophylaxically. But it is a main issue after a transplant. We see a lot that happens. They bleed, and then one of those chest tube clots off, and they develop and go to tamponade. But generally, rarely you need a window of this patient. That's why it's not done prophylactically. And also kind of protect your heart, even though that pericardium, putting it back. So it's not recommended for all the patient prophylactically to do window.
Okay, fair enough. Thank you.
Dr. Yousefzai, I have a question about if the patient has LVAD and then has ICD, usually do you after the LVAD, do you usually leave it on, the defibrillation?
That's a good question. I think that's kind of it's a talk by itself, but generally consensus are somebody has an ICD, you usually leave the ICD. That's an easy question. If somebody has an ICD, you leave the ICD. I think that the harder question is, if somebody doesn't have an ICD, should you put the ICD after LVAD? And if somebody has a CRT, if you should leave the LV lead on. I think those are like more difficult question to answer. There's no consensus on that, but somebody has a history of VT, they have a higher chance of having a VT after LVAD. So if they don't have an ICD, it's recommended to put ICD. Ischemic people with ischemic heart disease with a lot of scar, they're high risk. You should consider ICD placement. And then CRT is very controversial. You know, you can leave it on, but there are some thoughts that really the LV is supported right now, and you don't need the LV lead. And there are some centers, they have a protocol to turn off the LV lead to save the battery for this patient. So there's no 100% consensus, but your original question, if you have ICD and you leave the ICD in, that's an easy one. Okay, I think it's 103. If there's any more question, I think we'll leave it there. Thank you, guys.
Thank you.